let me remind you about what we're using ultrasound for, okay? So ultrasound is a tool for us to teach you clinical concepts, and our goal is to make you better doctors, okay, than those that didn't have ultrasounds. Last year what we did was we taught you correlative anatomy. We call that relationship anatomy. We taught you how one organ fits to the next organ and how one organ can affect another. And this year what we're going to do is be teaching you how to visualize physiology in action so that you'll remember that. And I'm going to show you a little bit of that today. It's really cool. And the reason why we're doing these things is if we can teach you a little bit better anatomy and ways to remember it, why it's important clinically, physiology, the same thing, then you're going to be better at picking out diagnoses and also helping you eliminate differential diagnosis off your list. Because if you have less things you're worried about might be wrong with the patient, then you're going to pick better tests and you're going to have better outcomes because you'll get to the diagnosis quicker. So this is how we break down the 4 years. You know, this first year over there, what we did is we taught you physical exam skills using ultrasound to help you see anatomy, all right, that relationship anatomy. And again, this year what we're doing is ultrasound augmented physiology visualization. Next year is even better, right? Next year, you're going to be out in the clinics, you're going to be out with preceptors, and you're going to be using ultrasound to actually make diagnoses, okay? So you're going to apply what we're teaching you, and you're going to see it really in action. In fact, this last year, we had one student that found a AAA, abdominal aortic aneurysm, on a patient that would never have gotten screened and would have died from it. Found it, patient got treated, now they've got a normal life expectancy. And then, you know, maybe you'll go on and do some of this in residency, and that's cool, but our goal is really to make you better doctors. We're also transitioning how we teach medicine. We're going to a more case-based format. So we're starting that with ultrasound. And so y'all all got a case. That's me that had a car wreck. And when you have a car wreck, you know, you come in on this long spine board and they strap you down. If you have broken bones, you're not moving around. Y'all have seen that, right? And so there's a 22-year-old person involved in a high-speed MVC, and they come in with abdominal pain. Now remember, pain is what your patient tells you. Tenderness is what we do to the patient, right? That's physical exam. So they have abdominal pain, but they also have a right lower quadrant bruise, and they're very tender to palpation. So you're thinking that they've got some kind of abdominal injury, right? But then you look at their vital signs. What do we see about the blood pressure and the heart rate? What is our diagnosis? Shock. This is shock, all right? So you already got your diagnosis. But I asked you to come up with a differential diagnosis, right? We already know a shock. What kind of shock is it, would you guess? Hemorrhagic shock, because they're a trauma patient, right? It all makes sense, right? Now, you know it's hemorrhagic shock. What kind of things are you thinking about? Spleen, very common. What else? Perforated bowel. Keep going. Liver, biggest organ in the abdomen, right? It's the easiest to injure. What else? Pelvic fractures bleed a lot, all right? So we've done a lot in the abdomen and pelvis. What other cavities do we have? Lungs. So if you had air leaking out of your lungs, that can make your blood pressure low. That's a tension pneumothorax. Or you're bleeding into your chest because there's a lot of blood vessels in your chest. If it was bleeding, you'd have bleeding in your chest. That could also cause your hypotension. What about around your heart? If you injured your heart, where do you think it would bleed? Around your heart, right? And that can cause your blood pressure to be low too. Now you got a bunch of things on your differential diagnosis. That's what the case-based format's to do, is to help you think about all the things that will be wrong. And now we're going to try and figure out which one of those is most likely, okay? So let's talk about the FAST exam. Remember, the FAST exam is how we ended last year, right? The FAST exam stands for Focused Assessment with Sonography and Trauma Exam. And what it is it's 4 letters, helps you remember, it's 4 windows. And what we're doing is we're looking for something. What are we looking for in the FAST exam? Free fluid. So what does free fluid mean? Free fluid is fluid that's not in the structure it's supposed to be in. It's leaking out. Now, we're looking around the body with 4 different views. Do you think that knowing where the fluid is would tell you something about what might be injured? Yeah. So we have to look for where the fluid is, and then we're looking actually in multiple places. But how many compartments are we looking in the body with the FAST exam? 3. Excellent. 3 compartments, right? What are those 3 compartments? Abdominal pelvic compartment. All right. What else? The pericardium and the thorax, right? And so we're looking at those 3 compartments around the heart, or in the chest and in the abdomen. If you saw free fluid, which in the case of a trauma patient, what is the free fluid? Blood. If you saw blood that was leaking out in the abdomen, you probably think that one of those things that we talked about, liver or the spleen or the pelvis, you'd think that was the injury, right? If you found blood around the heart, you'd probably think it was the heart that was injured. If you found blood in the chest, you'd probably think it was one of those big blood vessels in the chest. Well, how you can start narrowing your differential by where you find the fluid. So finding the fluid is really important. So does identification of the fluid help you with the differential diagnosis? Yeah, it helps you start narrowing it down. It doesn't mean that there's not injuries in those other places. But if you found a lot of blood in the abdomen and the patient was hypotensive, are you going to operate on the chest or the abdomen? Abdomen. You see how this works? All right, now, when you look at the fluid, what does fluid look like on ultrasound? Dark or black or anechoic, right? So if you look at fluid, does it tell you what it is? So what are the things, the fluid, what could fluid be? Well, in a trauma patient, you said it's blood. But what about if it was the patient that had liver failure? What would it be? Ascites, right? What about in the patient that had an infection, what would the fluid be? Pus. So how did you know the difference between all of those different kinds of fluids, but yet on ultrasound, they all look the same? How did you know? Your brain, you're going to use your clinical knowledge of what's going on with the patient to help you make a differential diagnosis and move things to the top of the bottom. This is really important. This is what distinguishes a good doctor from an okay doctor. The ones that can narrow down their differential and focus in on the ones that are most likely versus thinking about 30 things. Let's go back over anatomy. So, right upper quadrant, we have, what's the biggest organ in the abdomen? The liver, and then we have the kidney, right? And then there's a potential space between it because the kidney is retroperitoneal, so it's held down to the spine, whereas you have the liver that's in the abdominal compartment. So that dividing line between it has a name, we call it Morson's pouch. But we also can see the spine, see the spine in the back? And the diaphragm coming up over the liver. What's above the diaphragm? What compartment's above the diaphragm? The thorax. Notice that when you look at the spine, it stops at the diaphragm. Why does it stop? Why don't you see it above the diaphragm? What are our enemies of ultrasound? Bone, air, and distance, okay? So those are the things we can't see through. So what is the up here in the thorax filled with that prevents us from seeing the spine? Air. So if we see the spine coming up above there, then there's something that's not an enemy of ultrasound, right? There should be an enemy there, and there's not an enemy there, all right? What about the heart? So this is going back to that relationship anatomy we did last year. Remember, this is the liver, right? And what side of the heart is next to the liver? Right. The right side of the heart. And what big blood vessel goes through the liver into the heart? IVC. And the IVC goes to which chamber? Right atrium. So relationship anatomy. You found the liver. You knew there's a blood vessel goes through the liver, goes to the right atrium. So that's right atrium, that's right ventricle, that's left ventricle, that's left atrium. Remember how we did that last year? If you just need, only thing I ever expect y'all to be able to find on ultrasound is the spine, because that tells you where the back is. There's nothing past the back, and the liver, and that tells you right and left. And if you can do that, you can tell everything in the chest, and you can tell everything in the abdomen. You know what everything is, okay? You just follow it from one thing to another. Liver, this is the blood vessel going through the liver, so that must go to the right atrium. So that's right atrium, right ventricle, left atrium. Good? All right. What's this bright line around the heart? Pericardium. Notice that it, all right, what about the left upper quadrant? It looks just like the right upper quadrant, right? Except the spleen's a lot smaller. So you got the kidney and you got the spleen and the diaphragm still there. Here's the spine coming up and then it disappears. Why does it disappear? What's up here? Air in the lungs. And then the last view is down into the pelvis. Remember, we look for the bladder, right? The bladder is not free fluid, it's a contained fluid, but it's our window to see posterior. And so we see either the uterus or the vagina or the prostate, depending, right? So where will the fluid be, all right? So this is right upper quadrant. Remember, if you want to think of it this way, you know, the kidney is held down by that peritoneum, all right? So it can't go anywhere. But the liver is in the abdomen and it can float. So as you start filling up with fluid in the abdomen, the liver starts to float up. So this space is called Morson's pouch, right? And we're going to come back to this in a minute. It's not important to remember that it's called Morson's pouch. It's important to remember that it's important. Remember we've talked about that before? Why is this space important? Because this space is where fluid collects in the supine patient, all right? Look at the spine. See the spine coming up and it stops? So is there any fluid up in the chest cavity? No. So this person only has fluid in the abdominal cavity. And how do you know what the fluid is? With your brain, right? Clinical history. So if it's a trauma patient, what is it? Blood. If it's the patient that has liver failure, what is it? Ascites. And if the patient, and let's say it's a kid that has appendicitis, and it's ruptured. What is it? Pus. Here's another one. Look how much more fluid this is. Is this a lot of fluid? Yeah, it's a lot of fluid, but is that important or not? Well, if that was ascites, that might not actually be a lot of fluid for ascites, right? Ascites can be liters of fluid. But if that was blood, would that be a lot of fluid? That'd be a real lot of fluid, right? So you have to put it in clinical context to know what things are. What's this bright stuff? What's all this bright stuff? Bowel. Excellent. Excellent. So how did you know that was bowel? So what's bright on ultrasound? So fluid, yes. Fluid is dark or black, anechoic, and what's bright is bone and the other enemy of ultrasound. Air. So why do you have air in your belly? It's in your bowel, right? So that's bowel. Bowel looks like air because it's full of air. Here's another one. Notice you got the liver again, kidney. We see the spine. Oh, look, the spine's going above the diaphragm. Why can we see the spine above the diaphragm? Because there's no enemy there, right? What's there? Our friend. Remember, friend, air, bone, and distance are the things we have trouble seeing through, so I call them enemies. But fluid, we see better through fluid, so it's our friend. So that's why we can see the spine, so there's fluid there. So what do we call this fluid? Depends, right? If it's a trauma patient, what is this fluid? Blood or a hemothorax, right? If that's a CHF patient, what is it? Pleural effusion. Pulmonary edema would be in the lungs. This is outside, so it would be pleural effusion. What about if they had a pneumonia in that lung and they had an effusion around it? What would we call it? A parapneumonic effusion, right? It's pus. Here's the heart, all right? The heart, see the pericardium separated by fluid? Now, this is what we're going to learn this year. We're going to learn that fluid has pressure. And so if you have pressure in the wrong place, it affects how your organs work. So as the pressure and fluid around the heart increases, the pressure inside your heart decreases. If the pressure inside your heart decreases, then your blood pressure, what do you think it does? Goes up or goes down? Goes down. So the more fluid you have around your heart, it makes your heart not be able to fill with blood and you get shock. Anybody remember what that condition's called when you start getting shocked because of a pericardial effusion? You're going to learn it this year if you don't remember. It's called pericardial tamponade. Look at this effusion. Look, wow, that's a pretty big effusion, don't you think? So think about how your physical exam would be if you took a stethoscope and you were listening for that heart. What would it sound like? It'd be muffled, right? Does that make sense? Because it's a lot further away. It's the same enemy that ultrasound has. Remember bone, distance, and air? Well, this is distance, right? So your hearing is even less. Let's take a look. So spleen and kidney, and the kidney and the spleen don't actually have a Morson's pouch, so the spleen doesn't separate from the kidney. So, but you see the fluid coming up between the spleen and the diaphragm? But look, they got fluid above the diaphragm too, because see, you can see the spine coming up above. See that? So they have fluid in their thorax and in their abdomen, right? Does that mean they have one injury or two injuries? At least two, right? Because those compartments don't communicate, all right? What about this? So same thing. So you got spleen. Look at the spine coming up. That's a little easier to see, isn't it? Because it's a lot bigger. What's this stuff floating in the fluid? So what's normally in your chest? Lungs. But we can't see lungs because they're filled with what? Air. What do you think that is? Lungs. Why can you see the lungs? Because there's no air. Remember I told you on the heart, I told you that fluid has pressure. And when it has pressure, it affects the other things around it. So the pressure, because there's fluid, keeps the lungs from filling with air, so they're collapsed lungs. And now you can see them because there's no air in them. What do we call collapsed lungs? Do you know what this diagnosis is? Not pneumothorax. Pneumothorax is air outside the lungs. This is, collapsed lung is atelectasis. So this is compressive atelectasis. Okay. Here is down in the pelvis, and we have the uterus. Notice that fluid's our friend, so it's so easy to see the uterus. See how well you can see the uterus because it's got fluid on both sides of it. It outlines it. What's this space called back here, back behind the uterus? Rectouterine pouch, or the pouch of Douglas. We'll talk more about that in a second. Here it is in cross-section. You can see the bowel is outlined too. All right. So now that we've talked about that thing, let's talk about the application, because it's good that you know what it looks like on ultrasound, but it's better that you know how to apply the knowledge I just gave you. Okay, so does patient position affect where you find fluid? Why? If I was standing up and I had bleeding in my abdomen, where would the fluid be? Pelvis. If I was laying flat, where would it be? In Morrison's pouch. So it's not important to remember that spaces have names. It's more important to remember that named spaces are important. So Morrison's pouch is important not because old man Morrison described it. It's important because that's where fluid collects in the supine patient. Pouch of Douglas, same thing. That's where it collects in the upright patient. And costophrenic angle doesn't really have a cool name like costophrenic angle of lion, but you'll see that that's really important, and the pericardial space also is the same thing. Those are where fluid collects, okay? So let's get away from ultrasound. Let me show you how to apply the knowledge you just got to every situation, all right? So let's think about another imaging modality, all right? So let's think about, here's me. I came in, I'm a trauma patient. I'm strapped to this board, all right? Now let's say that I've got bleeding in my chest. What kind of test do you want to do to see if I've got bleeding in my chest? X-ray. Okay, so we're going to take an X-ray, all right, and we're going to look for that free fluid in my chest, all right? So here's the X-ray. Remember on X-ray, black is air. It's opposite than ultrasound, okay? Sometimes it gets a little confusing. Ultrasound and X-rays are backwards from each other. Do you see free fluid in this chest? Do you think there is free fluid? So it may not be any free fluid there, but it could be there. If it's there, why are we not seeing it? So he just said that air will rise and fluid will sink. Isn't that what you just said? And so air would come up and fluid would go down. So in other words, if you had air outside the lungs like a pneumothorax, it would come up here, right? And if you had fluid, it would come down here. But they're laying flat. So how do you think they did the chest X-ray? Do you think they did it flat, or do you think they stood them up on a board like this? Flat. So where would fluid go on this chest X-ray? It would just lay down along the back. So if it's laying along the back, do you think it's easy or hard to see? Pretty hard to see. So if you want to increase your sensitivity, what should you do to this patient? Stand them up. So that's why we prefer to have upright chest X-rays instead of flat portable chest X-rays, because upright, the fluid sinks down, so you get it here in the costophrenic angle. Now you know why it's called costophrenic phrenic angle, right? Is because it pools and we can see it. And if you had a pneumothorax, it would be up at the top, right? Whereas if you were laying flat, it would be layered anterior up here and you would miss it. Do you see how we are applying the information? All right, you want to apply it a little bit more? All right, let's apply it a little bit more. All right, so what about when you learn physical exam? Remember you would percuss, and if you're over an airspace, what does that sound that's over an airspace like the lungs? Resonance or tympany. And as you get over fluid, it gets more of like that solid dull sound, right? So if you had a pleural effusion and you were going to percuss it out, how would you do that? Would you do it flat or sitting up? Sitting up. Now, I understand. It's pretty hard to do percussion on the back with somebody laying down, right? So we always do it sitting up anyway. But do you see how that would increase your sensitivity? All right. What about then a pericardial effusion? All right. So a pericardial effusion, you go feel for a PMI. How would an effusion affect your physical exam? Yeah, the heart's further away from the chest wall because of the effusion, right? It's the same thing when we talked about muffled heart tones when you were listening, right? It may also displace it too, right? And then it's not a displaced because it's an abnormal heart. It's displaced because there's a pericardial effusion. Good? All right. What about if you had ascites? How do we know what the fluid is? Now, we said we use our brain, right? But what if you weren't sure? What would you do? Aspirate. We stick needles in things, right? We got to get some of it. So here's some ascites. What's all this stuff in the belly besides the fluid? Bowel. Do you want to stick a bowel with a needle? No. So that's a really small amount of fluid. Do you want to stick a needle in that? Or would you rather concentrate it and make it bigger, right? You'd want to concentrate it and get it bigger, right? Like this. Wouldn't that be a whole lot easier to stick a needle into? So what would you do to get more concentrated fluid? Roll them up on their side or sit them up a little bit, right? You seeing how you're applying your knowledge? All right, let's take it one more time, all right? So the things I just taught you is free fluid is gravity dependent. So you find it in different places depending on how the patient is. Plus, it helps you in your physical exam findings know what you're thinking, right? And it helps you apply your physical exam. But here is my trauma patient. They're laying flat. So gravity is not affecting their blood pressure. So in other words, fluid and also your organs is affected by gravity. So if I'm laying flat, so the gravity is equal all the way up and down. What would happen if this patient right here, laying flat, has a low blood pressure? Do you think that their blood pressure is really low? Yeah. But you've seen people that are passed out, like young people passed out. They're not bleeding out, but they pass out. Remember what you call that? Vasovagal syncope. They lose vagus tone and all their blood goes to their legs, so it's not going to their brain, so they, right? And what do all the bystanders run up and do? Sit them up, right? Where's the blood going now? To the brain? No. Nature made it so that when you lose oxygen to your brain, blood flow to your brain, what happens? You fall down. You get flat. Now blood goes back to your brain and you wake up. But then bystanders sit you up. You stay passed out. You understand? So, which one of these? So, if your blood pressure's low, do you think that this one's good? No. This is probably better, right? But you can use gravity as your friend, too. You can also put their head down. Now all the blood goes down towards their head and drains out of their legs. That's called Trendelenburg. All right. So did I teach you a little bit of physiology? Did you see how all of this is really important, and you can use ultrasound to figure this out? And that I'm telling you, when you guys hit the third year, remember this stuff. This is what's going to make you excellent doctors.